Good afternoon. Thank you for joining me today. Today we will be discussing hypertension, also known as the silent killer. We will be reviewing basics of evaluation and management. My name is Rosalia Treto. I am one of the nurse practitioners at the Heart and Vascular Institute here at Titus Regional Medical Center. I do work under the supervision of Dr. Sekulich, Dr. Abbas, and Dr. Siegel. All right, let's get started. So there's three classifications of hypertension. There's primary, secondary, and then there's hypertension crisis. The vast majority of patients that you will see in clinic or in the hospital generally have primary hypertension. About 90-95% do. This is the primary diagnosis. Primary hypertension is also known as essential hypertension. Hypertension urgency is generally considered blood pressure greater than 180/110 without evidence of acute end organ damage. And then you have your hypertension crisis, which is a blood pressure greater than or equal to 180/110 with evidence of acute end organ damage. Generally, these patients with either urgency or crisis will probably be sent to the emergency department if we're not able to lower their blood pressure in the clinic. And by that, I mean I give them maybe 1 or 2 doses of clonidine depending on the response I receive from it. If I don't get an adequate response to a safe blood pressure, then I will definitely send them to the emergency department for further evaluation and treatment. All right, so high blood pressure. What is really high blood pressure? So high blood pressure is when your blood pressure, the force of blood flowing through your blood vessels is consistently too high. Okay, blood pressure reading is measured in millimeters of mercury and is written as systolic blood pressure, which is the top number, also known as the force of the blood against the artery walls as your heart beats, which is over diastolic pressure, the blood pressure between heartbeats. How is blood pressure calculated? Well, you get your cardiac output times your systemic vascular resistance. And nearly half of all American adults have high blood pressure. Again, many just don't even know they have it. They're walking around, with blood pressures 200/100 and they feel great, which is why we call it the silent killer. Some of the risk factors for primary hypertension, again also known as essential hypertension, is age. Advanced age is associated with increased blood pressure, particularly systolic blood pressure. Obesity, huge risk factor. Family history and or genetics. Hypertension is approximately twice as common in subjects who have one or more hypertensive parents. So asking family history is extremely important. Race. We do know that hypertension is more common and more severe and occur earlier in life with greater target organ damage in African Americans. High sodium diet, excessive sodium intake of greater than 3 grams a day. So teaching patients to read those labels is very important. Excessive alcohol consumption. Physical inactivity, so exercise is actually a very effective way of lowering your blood pressure, just like it is lowering your glucose. Okay, these are some other secondary or contributing causes of hypertension. Major causes of secondary hypertension are, and these are just kind of classified, so I have prescription or over-the-counter meds. These are some of the most common ones. Oral contraceptives, especially those containing higher estrogen. NSAIDs, particularly with chronic use. You usually see this with patients that have like rheumatoid arthritis, osteoarthritis, chronic pain. Antidepressants, corticosteroids, rare cause of secondary hypertension, but it can. Decongestants, especially these two, phenylephrine and pseudoephedrine. I did have a patient yesterday who was in clinic she said her blood pressure is very well controlled at home. Yesterday I took it was 190/89. And she's like, I don't know what's different. And then the daughter is like, oh yeah, I gave her some pseudoephedrine before we came in. And there you go. Some of the weight loss medications, some of the common weight loss medications that you usually see with this is like phentermine. Okay, cyclosporins or tacrolimus, these are anti-rejection medications. Stimulants, again, amphetamines, phentermine, Adderall, Vyvanse, atypical antipsychotics, and then those were some of the medications. And then illicit drug use, you have your cocaine, crack, and then primary kidney disease, renal vascular hypertension, obstructive sleep apnea. A lot of people don't know that they have obstructive sleep apnea and they have other significant issues because of this. Pheochromocytoma is also, it's a rare, but it's definitely possible. And there's a whole slew of workup for this one. Diagnosis. So when evaluating an individual patient, making the diagnosis of hypertension is complex, and it requires repeated blood pressure measurements using appropriate technique both in and out of the office. I cannot emphasize enough the technique is so important to obtaining an adequate blood pressure, an accurate blood pressure. The following diagnostic criteria were suggested by the American Heart Association guidelines, meeting one or more of these criteria using ambulatory blood pressure, which would qualify for the confirmation of hypertension. As you can see on the screen, a 24-hour mean of greater systolic blood pressure greater than 125 or greater than 75 diastolic, daytime awake greater than 130, systolic greater than systolic or 80 greater in diastolic. Generally, the recommendations is doing a 24-hour ambulatory blood pressure monitoring. However, it is costly and not many people can have access to it, particularly like in rural areas such as ourselves. So what I tell patients is just monitor your blood pressure at home twice a day, morning and night, for at least 7 to 14 days, and then return your blood pressure log to the office, or if they're super high, I'll just kind of have them come back in within 2 to 3 weeks, and then we'll just kind of determine what the right treatment is at that time. But again, in order to establish the right diagnosis of hypertension, they do recommend at least 12 to 14 measurements that should be obtained both in the morning and evening for at least, it says here for over a period of 1 week every month, but I just tell them 1 to 2 weeks. And that's enough for me to establish the diagnosis. Let's see. So home readings should be used to complement office readings to determine whether a patient's blood pressure is under control. So let's say the patient comes in and they're super hypertensive, but yet they're like, oh, my blood pressure at home is fantastic. Okay, well, I don't necessarily take their word for it, but I'll just say, hey, monitor your blood pressure for me twice a day, again, for 2 weeks, and then return it to me. And if it correlates with what I had in the office, then generally, I will treat accordingly. And officially, hypertension is diagnosed if someone has a systolic blood pressure of equal to or greater than 130 over, and then diastolic 80. That is now considered stage 1 hypertension. Before it was 140 over 90, but that recommendation changed about 2 years ago, because they were finding that people who were more hypertensive, I guess, having higher numbers obviously was leading to greater target end organ damage. So the lower the blood pressure, the better outcome you have in the long run. And then what I was saying about the blood pressure being high in the office, generally we can call it white coat syndrome, which it's true, it really does happen. And then you have your masked hypertension. Sometimes, when you first assess your patient as a new patient, you always want to obtain 2 blood pressure readings, 1 in each arm, okay, just to kind of make sure that there's no significant discrepancy. Some of the things to consider if there are significant discrepancy is subclavian stenosis, peripheral arterial disease, or, rarely aortic dissection, but it can certainly happen. And you would see other symptoms and signs and a different complaint. So for patients who, as far as screening goes, for patients without a previous history of hypertension, guidelines recommend that you start screening these patients at 18 years of age, okay? A minimum of 1 year if they do not have diagnosis of hypertension, and at least every 6 months for patients that are at risk or family history. So, And here's just a little chart of what normal, elevated, and the stages of hypertension are now. And this is just a little chart of how to take your blood pressure appropriately, because like I said, that actually makes a huge difference in blood pressure readings in order to establish an appropriate diagnosis. So you always want to make sure you have the correct cuff size, because you don't want to place a small cuff on someone who has large arms, because that can definitely give you an erroneous reading or a high reading. You at least want to take 2 readings 1 minute apart. And before you take your blood pressure, you want to make sure you haven't exercised, you haven't had any highly caffeinated beverages or alcohol, at least within 30 minutes of measurement. And also, very important, empty your bladder before taking your blood pressure, because it certainly can elevate your blood pressure by at least 5 to 8 millimeters of mercury. You want to rest in the chair for at least 5 minutes with your arm resting at heart level. Okay, make sure you're relaxed. That is key. I'm trying to be relaxed today, right now. You want to sit still in the chair with your feet flat on the floor and your back straight and supported. All right, so before we continue, I just want to make sure everyone's paying attention. What is the target blood pressure goal that's for current hypertension management that has been established by the American Heart Association? Okay. Well, okay. No poll. That's fine. It is 130 over 80. All righty. Complications of hypertension. Again, this is whether it's untreated or treated, but you can have these complications with both left ventricular hypertrophy, just meaning some thickening of that left ventricle, which is, we can see it on an echocardiogram. Heart failure, whether that is reduced ejection fraction or preserved ejection fraction. Generally, with your reduced ejection fraction, you have some systolic issues or compromised systolic function. And then with your HFpEF, also known as heart failure with preserved ejection fraction, you usually see diastolic dysfunction. And again, those two are visualized on the echocardiogram by the cardiologist who is reading it. Stroke, intracerebral hemorrhage, ischemic heart disease, when that includes heart attack, chronic kidney disease, end-stage kidney disease. These patients, again, are either like on dialysis, hemodialysis, peritoneal dialysis. So, complications continued. So, hypertension is the most prevalent modifiable risk factor for premature cardiovascular disease, and this is way more common than cigarette smoking, dyslipidemia, or diabetes, which are the other major risk factors. Again, read this again. Hypertension is the most prevalent modifiable risk factor for premature cardiovascular disease. What I mean is that we have control. We can modify our risk factors to help prevent the diagnosis of hypertension. The likelihood of having a cardiovascular event increases as blood pressure increases. In a meta-analysis of over 1 million adults, risk began to rise in all age groups with a blood pressure greater than 115 over 75. Again, which is why the guidelines changed the new target blood pressure to be less than or equal to 130 over 80. The higher your blood pressure, the higher your risk factors. For every 20 millimeters of mercury, higher systolic, and 10 higher diastolic blood pressures, the risk of death from heart disease or strokes double. While hypertension is associated with a relative increase in cardiovascular risk regardless of other cardiovascular risk factors, importantly, the absolute risk of cardiovascular risk is dependent on age and other cardiovascular risk factors in addition to the level of blood pressure. Here's a little chart that just kind of tells you again what the prevalence of the various causes of hypertension are. And again, primary hypertension, also known as essential hypertension, is the top percentage here, 94 to 95%. Yeah. let's see. Alrighty, how do we evaluate and what do we do once we've established that the patients have hypertension? You always want to obtain a good history. Okay, you want to ask questions. What are you taking? Are you drinking alcohol? You always want to ask them, are you consuming any illicit drugs? That is crack, cocaine, Adderall, even though that's not illicit mostly. And then alcohol. Some people will lie about their alcohol consumption. You just got to tell them, ask them, I need you to be honest with me. Are you drinking this much? And when you sit down and ask them to be honest with you, they mostly generally are. Let's see, physical examination. You just kind of want to look for any signs of target end organ damage to establish cardiovascular disease. Some patients, when I say target end organ damage, usually you'll see some elevations in their BUN and creatinine. Again, protein in their urine, just other things that you would definitely notice as an abnormality on their labs or diagnostics. You always want to obtain an EKG, an echocardiogram, again, their renal function. You want to do a fasting blood glucose. Most of these patients have diabetes. Some of them are undiagnosed. And then you always want to check their cholesterol levels. Okay, again, here we are. The reason why I'm emphasizing blood pressure goals is because super, 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 super important that we get their blood pressure 130/80 or below to prevent any issues down the road. When I say over-enthusiastic treatment, what I mean is that you always want to take into account the patient's age, kind of what's going on with the patient. If it's like you're not going to prescribe the same amount to someone that weighs, 50 kilos versus 200 kilos. The treatment is going to be targeted differently, particularly with elderly patients. You want to start low because their blood pressures can drop pretty easily. They have, they are at increased risk for falls and then increased mortality in elderly and frail patients. All right, so how do we modify these risk factors? What can we do to help these patients? So first things first, lifestyle modifications. Lifestyle modifications entails like reducing their sodium intake, low-fat dairy products, maintaining a normal body weight. If they smoke, quit it. Decrease alcohol consumption. If they're the type of people that like to drink every day, 5 beers a day, 24-pack every weekend, just, they don't have to stop at 100%, but cut back. I always like to tell them at least half. Just do half. We'll start there, and then we'll just work our way down to eventually, hopefully, they'll stop. And I'll be honest, some of these patients, they'll tell you, I'm not going to quit. I've been smoking for 40 years, and I don't plan on quitting. And that's fine. You got to respect it, but you got to educate them and just make sure you inform them of their higher risk associated with smoking. Exercise, again, super important, and then the DASH diet, something that we highly, highly recommend in our office. Okay. Non-pharmacological therapy, also what we discussed, the lifestyle modifications, and here's just a little bit kind of what I discussed. But interesting enough, again, weight has a huge impact on your blood pressure. So if you if you lose about, 1 kilo of weight loss, which is like 2.2 pounds, your blood pressure can go down by 0.5 to 2 millimeters of mercury for every kilo lost, which is pretty significant. Let's see, and again, sodium intake. This is really important because a lot of patients think that Spam, Vienna sausages, bologna are ideal for your hypertension. No. So again, education, very important. Just, sit with these patients, discuss their diet, like what are you eating? And most of the time these patients are like, I eat healthy. Well, what is healthy? Tell me what you ate yesterday. And boom, there it is. I ate 2 bologna sandwiches. No ma'am. We need to talk about this bologna. Let's see. And this is honest to God. Like these people, this is what they eat. And unfortunately, some people just don't have the means to, eat other higher priced foods that are a little bit healthier. But so we just educate them on the amount, okay? Let's see. And here is just kind of there's a chart, I don't know if you can see on your screen, of the effects of lifestyle changes, okay? Weight reduction, here it is. It kind of gives you some numbers as far as approximate systolic blood pressure reduction, okay? Weight reduction, DASH diet, sodium, increasing physical activity, decreasing alcohol intake. You see, there you go, weight reduction, number one. And oddly enough, it's the hardest things, particularly for us women, you know? And we have so much control over this, which, yeah, that's another story. Alrighty. All right, so here we go. Treatment for hypertension. Who should be treated with pharmacological therapy? All right, so in general, we do suggest that antihypertensive drug therapy be initiated in the following hypertensive patients. Someone with an out-of-office daytime blood pressure of greater than or equal to 135/85, okay, or an average office blood pressure reading of greater than or equal to 140/90. Let's see. So, someone who has established cardiovascular disease such as CHF, carotid disease, history of CVA, even TIA, peripheral arterial disease, diabetes, CKD, chronic kidney disease, age 65 or older, or an estimated ASCVD risk score of 10%. So any of these people that I mentioned are absolutely important to initiate pharmacological therapy. Something to keep in mind too, people that have diabetes is generally associated with established coronary artery disease. All right, so some of the 4 classifications that we generally start with patients are thiazide diuretics such as hydrochlorothiazide, or if you want a little bit more blood pressure reduction, 15 to 20 points systolic, usually we can try and do chlorothalidone. Long-acting calcium channel blockers such as amlodipine, or if you want like a rate control, you can always do diltiazem. ACE inhibitors such as your lisinopril and enalapril. Now with these, one of the most common side effects are cough. Okay, so sometimes if this is an issue for the patients, they'll let you know, and you guys can discuss perhaps trying an ARB, an angiotensin II receptor blocker, such as olmesartan, losartan. There's tons out there. But I will be honest, my favorite combination drug is Hyzar, which is losartan and hydrochlorothiazide. They just seem to have this fabulous synergistic effect, and it just works fabulous. And just always keep in mind, a lot of the times I'll see this in clinic when I'm reconciling their medications. Some patients will be on an ACE like lisinopril and also like Benicar. ACEs and ARBs should never be given together because they work in the same area of the kidney, so it just defeats the purpose. Just kind of keep that in mind as well. And if someone's allergic to an ACE inhibitor, most of the time it is safe to start them on an ARB, okay? Again, you always just want to start low with these particular 2 medications. I always start, if I do an ACE, I usually start with like lisinopril, maybe 5 milligrams, again, depending on their weight and kind of or if they have other things going on like CHF, I would definitely do an ACE or an ARB, CHF with reduced ejection fraction. And then your ARB, again, just start low because if they have a reaction, you just want to make sure that you're not giving them a heaping dose of these medications. Let's see. And then, so African American patients tend to do better with thiazide diuretics or calcium channel blockers. If their blood pressure is still above the goal, then it'd be appropriate to add an ACE or an ARB as a second agent in combination. Again, I love Hyzar, again, losartan and hydrochlorothiazide. I love them. People with hypertension that have protein in their urine with CKD, ACEs and ARBs are first-line agent because they are renal protective. Hypertension with diabetes, ACEs and ARBs, and the reason for that is because they are renal protective. Hypertension with heart failure and decreased ejection fraction, you want to do beta blockers and or ACEs or ARBs, which also reduce the mortality, especially if they have a history of acute coronary syndrome. These patients with heart failure with reduced ejection fraction, typically we use carvedilol. It's more selective. And then we have hypertension with Afib, angina, essential tremors, migraine. Beta blockers are the choice because of rate control. And then other, for migraine, you can use beta blockers or tremors, essential tremors, tenolol. Unless other indications for their use is there. And then hypertension would be with BPH. You always want to use an alpha blocker. Like a lot of patients are already on alpha blockers, but I know Dr. Siegel loves doxazosin, works wonderful and does not affect your kidneys. Let's see, and then here we have this, just pretty much talks about if the single agent does not control your blood pressure, then a combination therapy is recommended, okay? If you have someone with a blood pressure of at least greater than 20 systolic and 10 diastolic, you definitely want to maybe do you also want to do a combination antihypertensive therapy, such as a thiazide, an ACE, an ARB, or a calcium channel blocker. All right, so a lot of patients that have uncontrolled hypertension, they are on more than 2 medications, which would entail perhaps a third drug, okay? I like to add hydralazine, doxazosin. This, like I said, is very popular with Dr. Siegel. And then I also like to do clonidine if they have resistant hypertension, meaning that their blood pressure just is not being controlled with their current regimen. There are so many medications out there to control blood pressure, so we just got to do the best we can and just try and prescribe the appropriate blood pressure for these patients, because not everybody is the same. If one blood pressure regimen works for Mr. Jim, it's not going to work for Mr. Kathy, because they're, whether it's race, ethnicity, age, weight. It's just everyone is different, so you always want to adjust medications accordingly for your patients. And then let's see, last pearls. Okay, I'm going to get on my soapbox here. I absolutely love teaching my patients about hypertension. And it's not that they don't care. Most of the time, these patients just don't know any better. They think that a blood pressure of 150, 160 over 70, 80, 90, it's totally fine. It's not okay. But they don't know that because nobody's ever educated them on. So take 5 minutes of your day just to teach them, go over the basics, what their goal blood pressure is, things they should be looking for. Teaching them to self-monitor at home is, my gosh, I cannot emphasize how important this is, because again, some of these patients will come into the office and their blood pressure is extremely high, and I ask them, are you checking your blood pressure at home? No, but I feel great. Well, guess what, buddy? We're about to start checking blood pressure at home. And sure enough, I tell them why it's important to check your blood pressure, what the risk factors associated with uncontrolled high blood pressure are. And they listen because they don't want to have a stroke and a heart attack and, anything like that, or be on dialysis. So talk to your patients, educate them, just tell them how important it is, and then have them monitor their blood pressure at home for you. And then just drop off a log. They don't even need to have a visit. At least I don't make them, unless they're super hypertensive or I'm concerned about other things. We'll definitely be coming into the office and we'll be discussing this face-to-face. But again, education, teaching them how to take a blood pressure is very important. Some patients that have, and it also depends on which device they have. So inquire about, tell me what you're using at home. How are you using them? Have them show you in the office how they're checking their blood pressure. Some patients have the little wrist device, and when they check their blood pressure, it's like their wrist is on near the floor. No, it needs to be at heart level. So again, education. And then if we have questions about their blood pressure, if we think there's a significant discrepancy in home readings and our readings, I always have the patient just come in, bring your blood pressure in. You don't even have to have an office visit. You just come on in, and then we'll check it against ours, and then that way we can establish if it's correlating and seeing if their home blood pressures are accurate. Because again, if there's a huge discrepancy, you don't want to overtreat a patient or undertreat a patient. Does that make any sense? Okay. And then also, because all these, most, like 99% of the medications that we do use as an antihypertensive drug, they can greatly affect your renal function. So very important to keep a close eye on your BUN creatinine. Just have at least a CMP every year at minimum for these patients, unless they're like on a diuretic, whether Lasix or even spironolactone, which is a mineral corticoid receptor agonist. That's another thing we use for heart failure with reduced ejection fraction. But these particular medications, again, they all affect your renal function. So keep a close eye on their renal function, okay? And again, some of these patients will have elevated BUN creatinine and compromised renal function because of hypertension, untreated hypertension, or just poorly treated hypertension, or, it's just, that's kind of what happens. And then something else, just talk to your patients, just educate them. And you can always just do a referral to the Heart and Vascular Clinic for just, for blood pressure. If patients aren't managed appropriately by their primary care, send them over. We have slews of medications that we can use to try and get their blood pressure adequately controlled. And and if we can't, then we will send them to, I have sent them to a specialist in Dallas who, I guess they have other tricks up their sleeve, but either way, we will take care of them. That is our goal, is to take care of these patients to prevent all these issues, stroke, heart attack. Nope, we don't want any of that. So, and something else I just kind of want to mention, patients that are Spanish speaking, take the time to educate them, because, hypertension unfortunately affects Hispanic African Americans the most, and some of these patients don't know that they're super hypertensive and they could be having a stroke or whatever, because they just don't know, okay? So if you don't speak Spanish, grab somebody that does and just quickly just say, okay, this is what I want you to look for. This is what I want you to monitor. These are the numbers, okay? I've had patients come into my clinic that don't know how to read or write, okay? Those patients, it doesn't matter. We're gonna take care of you. I will sit down, they're Spanish speaking. I will talk. They usually have their loved ones with them, the daughter or son or whatever. I talk to both of them. I sit down and I educate them, because if you empower one with knowledge, then the other, you're empowering both of them with knowledge. So, and together, like I said, the outcome is just so much better. So just take that extra 2-3 minutes just to really, really sit down with your patients and just show them. And I think the outcomes will be so much better for you, for your patients, and then for this community. So just educate. Alrighty? Any questions from anybody? Oh. Okay, questions. Oh, hold on. Before we proceed, I have like 2 more slides that have questions. In an asymptomatic patient whose blood pressure is consistently greater than or in the 150s over 70s, which class of hypertension would this fit into? Did they answer?
Not yet.
Okay. All right. Which of the following drug is not recommended for first-line monotherapy for management of hypertension? Is it A, amlodipine, which is a calcium channel blocker, enalapril, which is an ACE inhibitor, atenolol, which is a beta blocker, losartan, which is an ARB, or hydrochlorothiazide, which is a thiazide? No, let me see. I can't see. Atenolol, yes, excellent. Thank y'all for listening. Okay, we've already address this one. Ignore it. And these are just my references. Up to date. Oh, also, I think everyone here at the hospital, if you have access to Epic, you have access to Up to Date. Excellent, excellent, excellent resource. So if you have any questions about which medication to use, what dosage to start, what kind of diagnostics you need to follow up with, what do they mean, Up to Date is going to be your Bible. You go to Up to Date. And again, if you have any questions or just concerns or just unsure, there's Dr. Siegel, Dr. Sekulich, Dr. Abbas, and me. All right, thank y'all so much. I hope you guys learned something. So, again, take care of all your patients, okay? All of them. All right. Thank y'all. Y'all take care. Bye-bye.